the basic tenets of what's going to conquer this disease and make us have a normal life again haven't really changed that much. It is reducing exposure, which has a lot to do with masks and distancing. Those have been fairly consistent. It has a lot to do with doing enough tests so that we know where people are getting this and make sure that we can isolate. And it has a lot to do with contact tracing and syndromic surveillance.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, our guest joins us from the high-tech city of Boston. Please join me in welcoming Dr. Jonathan Teich to the Business of Healthcare podcast. Dr. Teich is the Chief Medical Information Officer for InterSystems. In the world of healthcare, InterSystems solutions empower providers, payers, clinical laboratories, and life science companies with creative data technology. Welcome to the podcast, Jonathan.
Bob, it's great to be here. Thanks for inviting me.
Well, being from the Boston area, I'm not surprised that you are a product of Harvard Medical School and also have a PhD from MIT in electrical engineering and computer science. And you have a long history and love affair with creative data technology. So before we get into our discussion topics related to COVID-19 and syndromic surveillance and contact tracing, we hear a lot about AI, predictive analytics, simplifying data. It all becomes a bit overwhelming. So please share with our audience a high-level view of what's involved in your world of creative data technology.
Well, sure. So as you mentioned, I'm the Chief Medical Information Officer at InterSystems. And in that particular role, I'm really focused on trying to amalgamate all of the different kinds of data that we collect from hospitals and from health systems and from billing systems, and even some of the things you do in your daily life, like knowing how many prescriptions have been sold at the local CVS, and really try and put all that data together to try and give it some meaning. There's tremendous sources of data out there, and they are both rich and very much fragmented. And it's really our job at InterSystems to really put that together, try and give you a view that you can use if you're a physician, if you're a quality leader, if you're a business leader, to really answer your questions. And it really kind of goes all the way back to my own history, which is a combination, as you mentioned, of looking at medical data, designing medical electronic health records, and being able to design various kinds of knowledge-based systems that help make people know what to do as well as know the data, what to do it with. It's a nice combination.
Well, it seems like just a tremendous assignment to do this type of work and really to address it to the appropriate end user, if you will. And so I'd like to get a better feeling for how that is done. On a personal basis, if I go to an academic medical center here in town, and they have an electronic health record, a popular one. I think they use Epic. And if I go down to another public hospital, not a public, but a private hospital, like a medical city, and they have an electronic health record. And I would think it would just be a natural thing that data could be shared. And is that pervasive yet, or is that still a wannabe? We want to have that happen.
It's getting incrementally better, but there's a long way to go. And we spend a lot of our time at InterSystems trying to fulfill that gap. And you can, just to give your example, let's say I've gone to one hospital that has Epic, but let's say that they referred me to a doctor over here who's using a different system like Cerner or another major system. And then I also get some therapy over here where they use something else. What happens is you find yourselves with lots of overuse and lots of lack of connection. Imagine if I'm on a care plan. Let's say I'm a patient that has kidney failure, and they've sent me to the kidney specialist here. Maybe I have diabetes. They've sent me to the eye specialist over there. And somebody has to be helping me coordinate all of these different things, helping me coordinate my entire medical life. And right now, with these things all over the place, we just don't know what's going on. In my part-time life, I'm still a practicing emergency physician at Brigham and Women's Hospital in Boston. And that means I see people who are coming in with problems, and I have the information that came from my hospital, but I don't necessarily have the information about what happened when they went to the mental health clinic over here, or they were doing some kind of smoking cessation clinic over there, and maybe they had an electrocardiogram at one place, maybe they had a CAT scan at another place, and I don't know. And if I don't know, I'm going to be prompted to do that test again. I once saw a patient not long ago who had actually had 12 CAT scans of his abdomen because they kept going to different centers and they kept not really knowing what had been done elsewhere. So in terms of coordinating your care, in terms of getting you one solid care plan, because there's only one of you, right, Bob?
That's right.
And you should be able to connect to all of your life. And then in terms of being able to reduce the excess wasteful use of these extra expensive tests, in terms of being able to sometimes prevent some admissions. Because if I have someone who's coming in with chest pain and they have an unusual electrocardiogram, but I know that somewhere else they had an electrocardiogram and it's the same, then I'm good. I don't have to admit them. So all of this comes down to coordinating, unifying, aggregating data, which is not kind of the status quo, really, not yet in this country, and which is something that's really, really important for your care.
Well, that's what a lot of these authors who are physicians writing about, is the anecdotal stories of these 9 CAT scans and things like that. And you stop and you say, talk about inefficiency, talk about cost. All these things are just terrible drivers for a business. Why would we continue on that way? I don't know if you've ever seen this parody. It's a YouTube video, and we show it in our class. And I think it's entitled, "If Airlines Were Run Like Hospitals." And it's so funny because a guy's trying to travel across the country and there's nothing connected. There's nothing connected. It's about 6 minutes long, and people usually are about to pass out. They're laughing so hard when they see that. But it's really, really true. I mean, some of the questions that are asked, just for your own benefit, I'll send you that link later on offline here.
Sure, because I had to see it.
But it kind of tells the issue here of this connectivity. And you're a technology guy. I mean, you know this technology better than most. Is there something in the future which will unite us? Is it going to be a Google, an Apple, Amazon, a combination of with Cerner and Epic and others? Where do you unite this data? How do you get it so that the general public can use it? And is that the interest that you're in right now, or are you just doing it for specific hospitals?
Well, it certainly is what we do. And as standards slowly and hopefully inexorably make their way to unification, we will continue to try and stay on the leading edge of that. What is the best? I think, what I really put my biggest hopes in is the terminology or the data structure known as FHIR, Fast Healthcare Interoperability Resources, FHIR, and it's called FHIR. And that has been something which has taken over a lot of the interchange standards over the past 7 to 10 years. What's different about it is that the way people did try to exchange data in the past has been through these very, very detailed coding systems. HL7 is the name of one of them. They've been used a lot, but they've always been subject to local variation. One of the nice things about FHIR is that it's kind of clinically designed from the word go. And so there is a FHIR structure that's particularly about medications, another one particularly about my medical problem list, another one particularly about laboratory tests, in ways that are, I think, easier to use. And what's happened is that FHIR has managed to take hold. There's lots and lots of puns about that word, I'm sure you know. And that's made it possible for people to exchange data with a little bit more meaning. It's also, for you technology people out there, it's also kind of easily available in a REST interface, which means that it's kind of easy for one application to make a request for FHIR data to another web-based application. So it's probably the best thing going now, and it has given us some additional hope that we can do this much better and much more easily.
Did it come out of academia, the government? What's the origin of the fire?
It was sort of a combination. It came out of the standards organizations, and there's a particular gentleman named Graham Grieve who was kind of the father of all of this, who works kind of in both industry and academic channels. And there's a whole subculture in informatics of people that work on standards, and I think they've done a pretty good job with that. But more than that is they did enough marketing, enough socialization that it has actually taken hold in the mainstream world, because some of the past ones that were tried might have had some good qualities to them, but really couldn't get enough emphasis on the part of some of the big companies like, Epic and Cerner and the rest to really make that strong of a difference. So that's one thing.
Did the Affordable Care Act help drive some of this information exchange?
It did, actually. It did in a number of ways, because it did, as part of its code, insist that there be various kinds of data exchange that goes on. It did support the use of standards. It set up a whole kind of standards body. I was actually working with the Health and Human Services part-time during that period of time, and there was a body that actually started to say, let's use this standard and this standard and this standard because we had to. And so I think that legislation has helped. More recently, the 21st Century Cures Act that was passed a little while ago, and which is going into effect in the next few months, really, has said a lot about making sure that people can easily get access to their data from a payer, from a provider under the right circumstances, and also saying that companies cannot block information from being exchanged. So yes. I think the government has started to hear that lesson as well.
Well, good. Well, let's shift a little bit into a topic of interest. And
sure.
I not that those weren't, but the general public today, boy, talk about infotoxology. So much information. We're poisoned. The general public, they don't know what to believe, what to see, what to do, how to do it. All these things are really confusing at times. And the topic is COVID-19, of course. And we hear about things like contact tracing. I'm not sure if there's a plan underway. Maybe you can give us some background on that. And another term that we're starting to hear more about is syndromic surveillance. And I think the CDC's been doing some of that, but maybe you can enlighten us all, kind of take us down to ground zero and bring us up to what's going on with COVID-19 in this area.
It's certainly occupying many hours of our day. It's very, very deep in our thoughts all the time. We've done a lot of work on that we can talk about as we go along. But absolutely, you said that we don't know what to believe. The truth is that, like any brand new disease and brand new field of science, we're trying to recreate what would normally be 15 years of science in about 4 to 5 months. So that's why some guidelines change as we learn more. But in truth, the basic tenets of what's going to conquer this disease and make us have a normal life again haven't really changed that much. It is reducing exposure, which has a lot to do with masks and distancing. Those have been fairly consistent. It has a lot to do with doing enough tests so that we know where people are getting this and make sure that we can isolate. And it has a lot to do with contact tracing and syndromic surveillance. So let's talk about those. As you know, a lot of the spread of COVID-19 has been set by these sort of local events, what they sometimes call super spreader events, where people come to a conference and it turns out that there was somebody sick at the conference and for whatever reason seemed to have the right properties to spread their illness to many people. And suddenly there's a pocket of illness. Well, if we go and let that pocket go unchecked, then all the people in that pocket, one of them takes a trip to New York and one of them takes a trip to Colorado, and then they spread that elsewhere. And it's a normal exponential contagion that goes on. Whereas if I find out that person number one had this illness, and then I say, oh, well, if you had this illness, then everybody that you have been in contact with for more than 10 minutes or without a mask for the last 12 days, they might have caught it also, or they might be at risk. So let's find all of those people. let's find all those people, whether they're sick or not. And let's tell all of those people to get tested, to isolate yourself, because some of you are the people that have the next wave of the illness. And some of you, if you don't know it, are going to spread it further. But if I start with person A and I say, okay, let's go to the 20 people that person A was in contact with, test all of those people, isolate all of those people for a couple of weeks, then I can probably contain that spread. So that person A is no longer sending their disease out to thousands of people. It's like a bubble. The bubble can explode and go everywhere, or I can try and contain it. So the role of contact tracing is to do that one person at a time, very painstakingly, to go and find these people. If I identify a case because a positive test came in, then go and phone that person up, find out with detailed questions who they have seen, who they've been in touch with, and then go find those people's contact information and phone them up and do that. So contact tracing is a one person at a time, individual by individual way of trying to contain this by containing each person that could start a spread. And it's going to be different from syndromic surveillance, which we'll talk about in a few minutes, but that's kind of the nature of it. And many states are doing this now. Massachusetts was actually the first, I believe, to come out with a tracing program in force, and there were a couple thousand people who were hired to do that. And our numbers in Massachusetts, fortunately, have come down quite a bit, so we're not doing as much of it, but we have people at the ready. And many other states have taken this on now in different phases.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
It would seem that the timing to invoke contact tracing would be as early as possible. Is the genie out of the bottle now? Is it? I mean, you look at the exponential spread and you say, like here in Texas right now, they'll probably come out today and say that 1,000 people have tested positive, and tomorrow will be 1,500 people have tested positive. And how do you begin to invoke a contact tracing model when you're that far down along the line? I mean, it seems like you couldn't do it.
It is indeed much harder in places where we have already seen the explosion of community spread, because any one person in Florida may have caught it from 3 persons. So it's very difficult. So for Florida, for Texas, for Arizona, for Los Angeles, for the other places that are having explosions right now, it's a little bit harder to do that. It's really important and contact tracing and syndromic surveillance are really most effective at holding the line. They're not as effective necessarily at trying to bring down something that's already, as you say, out of the bottle. But the numbers will go down. There will be waves, and the thing to do is to be ready and to catch them at the time when we can do some interventions on that. Syndromic surveillance plays that kind of a role. So syndromic surveillance is really more about population level. How do I find out whether an entire community has become a hotspot? So before Florida became kind of exploding, there were pockets in a couple of particular cities. And the role of syndromic surveillance is to find that out. The role of syndromic surveillance is to collect data from lots of places that are doing testing, from lots of medical centers that are admitting patients, from lots of clinics where patients are going, even from lots of drugstores where patients are coming in for an unusual number of prescriptions for Tylenol or cough medicine or something, so that we can infer that there's something going on over there. And with syndromic surveillance, you pool this data, and you have to work very hard to normalize the data to make sure that what one person thinks of as a prescription is the same thing as what another system thinks of as a prescription. There's your interoperability. But if I can pool that data together, I can make maps. I can figure out that, hey, this particular zip code over here, which had 2 cases before, now they've got 20 cases. Something's going on. Let's grab our contact testers and let's send them en masse into that region. Let's make sure that there's lots of people being checked. Let's make sure that they have enough resources and tests and PPE, protective equipment in that area. And then maybe we can get that area under control before it becomes something which spreads to other areas. So the role of syndromic surveillance is saying, can I figure out when something is suddenly growing? Can I figure out when something is rising and try and stuff it before it gets out of hand?
That could be applied. I mean, syndromic testing, you don't have a pandemic to put that to use, but you could look at that in terms of food supply, recalls, any type of other data, I'm sure. Where does the data come from? How do you put together a network that brings timely, reliable data that you can start to, model it with?
Syndromic surveillance can, in fact, as you say, be used in lots of other situations. And, we get a lot of our knowledge about contact tracing and syndromic surveillance from work that's been done overseas in Africa during the time of Ebola, in other kinds of epidemics that go on, to tuberculosis and malaria in low-income countries. A lot of the work that we know what to do about these techniques comes from those countries. So yes, they can absolutely be used for anything from tainted meat that seems to be affecting a large region to people that have been displaced by some other disasters. After Katrina, there was a lot of syndromic surveillance that went on to try and capture people as they were being displaced. So it can be used for lots of things. The data comes from lots of the same sources that you would think about. It comes from medical clinics. It comes from local public health chapters. InterSystems, for example, works with a lot of state health information exchanges. So most of the states of the U.S. have health information exchanges, one or more than one, which collect data from lots and lots of constituent hospitals and clinics and pool them together. And they give a lot of great public health knowledge. So we work with, for example, I think we work with 13 or 14 of the state HIEs, the health information exchanges. We work with Healthix in New York City, which is very, very large, has like 25 million patients, 25 million persons in their overall data ranks. And they collect data from lots of different health centers, and they do a lot of reporting of that up to public health. So it's health data. It's the same kinds of things I talked about. But what's really difficult is trying to make all that data make sense. So there's so many different codes for the tests that are being done by different manufacturers. We have to pool those together. There are different codes about how people interpret, is this a COVID-related admission or not? So a lot of it is cleaning data, which is one of our specialties, and saying, okay, yes, we got all this data. Now here's data that actually makes sense. And that's the root of what you can use for these analytics, for these machine learning tools, whatever else you want to do to execute your syndromic surveillance.
Wow, that's really interesting. You would think maybe that the government, would it be the CDC, would they be strong advocates or users of this syndromic surveillance?
CDC is certainly historically very motivated to do this. And I've worked with them before on similar situations in my own, and of course, many other people who have worked together on this. CDC is very interested in creating national level data collections. They do have certain kinds of databases that can collect certain things. The way the US works, it's difficult to get too much of this data pulled into one massively central area. Just like collective action seems not to be in our American DNA so much, which is one of the reasons why we're having so many problems with COVID-19.
Right.
By the same token, collective data capture is sometimes difficult because of people's concern about privacy or people's concern about proprietary ownership and business uses of data. So it's been difficult. And, so CDC has been interested in this. Their role has not been perhaps as forceful as it could have been under other certain kinds of times. So we're getting a lot out of the states, and they're doing things. And there's a lot of grassroots efforts that are trying to pull together some of this material. I'm sure most people have seen those black and red website charts that come from Johns Hopkins or from a number of coalitions going on around the country that are collecting this kind of data.
Yeah.
And we, as in the work that we do, we certainly support the efforts of these state-based things. So a lot of the state-based health information exchanges, from New York to Nebraska to California, they have used our work, our technology, and they've been building these reports. They've been building analytics which help them do some of this syndromic surveillance. They've been reporting them to their state agencies, and it's a big help. It's been one of the few ways that we really know how this pandemic is progressing.
I like what you said earlier, Jonathan, about simplicity, taking this complex set of data, cleaning it up, making it understandable. And I'll just give you an example, as a person living here in Texas, and as the reporting of information comes out, I'll hear that, hey, so many more people have been tested and have proven to be with COVID-19. And to me, that means nothing. So I'd like to know, so they were tested, how long did it take for them to get the test? And to what degree did they test? Is there such a thing as a scale of you've got a little bit of COVID-19 or a lot? When you got tested, did it call for you? So 10,000 people were tested. How many people actually showed symptoms? I don't hear the data on that. And if those that had symptoms, how many were seen by a physician? I don't see that data. And how many were admitted to a hospital? And how long was their hospital stay? And how many had to go into, critical care, intensive care at the hospital? I just think that if you start to peel back that data, it becomes more relevant to people, and it kind of removes maybe some of the fear factor, because you hear a number and you go, wow, you have this cognitive bias that this is scary, this is really bad. And maybe it is, and maybe it isn't. Do you know what I'm saying about making that data more realistic?
Oh, Bob, absolutely. I couldn't agree with you more. I think that in some sense, it's very important to understand numbers for testing and numbers for actual illnesses. That's really important for epidemiologists. It's really important for doing some of these techniques I'm talking about. But at a public level, we're certainly having a hard time explaining the value of understanding numbers of cases when we're doing numbers of tests. Now, there's no question that actual cases are going up, and there's no question that we have a real live and still very much growing epidemic going on. But I think that we need better presentations to show that. For example, we know that case numbers are going up. We also know that tests are going up. How do I relate that? Well, I can show you a data presentation that's clearer, which says, hey, the case numbers are going up 3 to 4 times faster than the testing is going up. So that means that we're actually getting more sick people. Furthermore, you point out that you can't find information on how many people are getting hospitalized, but there is that data that actually exists, and I know where to find it, and people have compiled it in various ways, and we help compile it. And I think that it's much more compelling to me when I look at the curve of new hospitalizations compared to looking at the curve of new cases. Because you're right, we know that some people are getting COVID-19 and being very sick, and some are getting COVID-19 and not being very sick. But the ones who are getting hospitalized, they're all sick, and that's real. And if you looked at the curve, you would see that that one's going up quite sharply also. And that would probably make you much more concerned than the test numbers alone.
Yes.
So I think you're right. We do have to show things like hospitalizations. We do have to show deaths, which did go down for a while, but now unfortunately are starting to track back up again. So those are the numbers that I think probably mean more to the American public that has to really respond to this epidemic with action.
Yes, I'd like to see David Muir, ABC News tonight, introduce Dr. Teich and have an explanation of this. It makes more sense than the fearful numbers we see sometimes. Okay, this has been very helpful. This has been very, very enlightening. I hear people talk about things like doubling rates. Someone said, and maybe you can validate this or dispel it. Doubling rates right now with the current mitigation across the country, the doubling rates of these cases is about 6 to 8 weeks. And someone said, and right now we're about 8%, maybe 9% of the people have been exposed to COVID-19. And if the doubling rate's about every 2 months, then just do the math out there. We're at 16% by November, and by January, we're pretty quickly getting up to 60% of the people exposed to it by the first of the year. Is that approaching what we would call, the herd immunity? Or is that does that make a sense of measure that's got meaning for us as well?
I would say the two answers are probably not, and we really don't know.
Okay.
So I try to be honest about this, Bob.
Yeah.
Probably not, because I think the numbers in many parts of the country are smaller. If you look at the testing rates in Florida and you look at the number of persons that test positive, I've seen numbers that are in the 11 to 12% area. I know that people have been questioning some of those numbers. There were some more localized tests where we could see in certain regions there was as much as a 30 to 40% prevalence in very small areas. I think that because of the different nature of the tests, and particularly because we're not testing kind of randomly, right? Ideally, we would test everybody.
Yes.
Ideally, everybody would come in and get checked every 2 or 3 weeks, and we'd have some real numbers. And that's conceivable and it's possible, but that's not how we're doing it right now for supply reasons and activity reasons. So I think that the numbers that we need to get to herd immunity, the 60, 70% of the population, it seems like that's still quite far away in many areas. And I think that a lot of the flattening the curve, a lot of the idea of trying to slow this down, a lot of the things that we're doing with masks and social distancing, that's by no means futile. That's really helping us to, first of all, keep the hospitals from getting overwhelmed, as we know.
Right.
But it also buys us time as we start developing therapies. The treatment of COVID-19 is more sophisticated now, still in its adolescence, but it's better than it was before. We learned things about how we should or should not intubate certain patients and how that makes a difference. We're learning things about certain medication therapies that might be helpful. And we do still have people working on the vaccine, and we don't quite know how far that is, but we hope that will be available at some point. So I think we're not achieving herd immunity. I think that we will do so only over a pretty long period, which might be, more than a year. Now, I am not a student of that epidemiology, so any numbers I give you here are not. This is not my expertise area.
Right.
But and we don't know because we're not testing symmetrically or we're not testing uniformly. But if we can sort of continue to get this kind of surveillance data, that actually is useful because that tells us the health impacts. And that's going to be something we can use today and which we can use to suppress the spread of this.
Well, I'm just glad that we have such a vibrant healthcare community. Obviously, the people in the front line, the scientists, the information managers like yourself, all working together. It's not like you said, one person can solve this problem, but it's refreshing to me to see the dedication and the hard work that everybody's pulling together to really address this problem. And I think we will have a good outcome. And I think the benefit is going to be way beyond our imagination. This is kind of like going to the moon. You go to the moon, you learn a lot of stuff you can use back here on Earth. I think we're going to learn a whole lot of stuff here with this COVID-19 that'll help us going forward, not just, medically, business-wise, personally, philosophically, socially. I think we're all going to benefit from this. And I just want to thank you. We've been listening here to Dr. Jonathan Teich. This has been a really great session, and I'm so glad that we can share this with our audience.
Well, it's been a pleasure, and you're absolutely right. We will learn things here that we can use in the future. I think that just as the people who had to experience the first SARS and the first MERS were more prepared for this, I think we will be prepared for things in the future, which hopefully will not come again in our lifetime. But there's going to be more epidemics, so it's good to have that skill. But it's great to be part of a couple of different efforts to do it. And as you say, there's thousands, if not millions of people who are working on this as their everyday job. So I think that good things must follow from that. Bob, it's been great to talk with you.
Thank you so much. We appreciate it.
Thanks for listening to the Business of Healthcare podcast.
Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.